So this is nursing care of the child with an alteration in cellular regulation, which includes hematologic and neoplastic disorders. So let's first just talk about blood. You've got erythrocytes, which is red blood cells. This is what transports oxygen. They transport some nutrients, collect and bring back some other waste, but the big thing that erythrocytes do is transporting oxygen. Thrombocytes, this is your platelets. They're responsible for clotting. Leukocytes, which are your white blood cells, are responsible for fighting infection. And then we divide the white cells up into granulocytes and agranulocytes. So those granulocytes, you can tell them because they're nucleus. They have, they're multinucleated. So they're neutrophils, eosinophils, and basophils, and then the agranulocytes are lymphocytes and monocytes. And if you hear somebody use the term that it's got a shift to the left, that's to our granulocytes, particularly our neutrophils, which are the first bacterial fighters that come out. They're the white blood cells that are the first and best bacterial fighters. So when we see that shift where you're starting to make lots of neutrophils, it's kind of an indication that whatever you have is bacterial. So in that CBC, we have a red blood cell count. This is just counting the numbers of red blood cells. It's in a specific volume of blood, how many red cells are in there. The hemoglobin is what's on the red cells that actually carries the oxygen. So hemoglobin can be measured just by measuring the actual hemoglobin, the heme there, or hematocrit. Hematocrit is a percent where we spin the blood and separate out the plasma versus the red blood cells. So those really all, red blood cell count, hemoglobin, hematocrit, are different ways of looking at the same thing. We're asking, is there adequate oxygen carrying capacity of your blood? Then we have those red blood cells indices that look at how big the cell is, how much the cell weighs, what percentage of the cell is hemoglobin. All of those things are really important only if you're looking at a chronic disease, because you start compensating by making the cells bigger, putting more hemoglobin on them. But in an acute infection, they don't mean much. White blood cell count. Again, we're counting how many white blood cells in this much volume of blood. And then we do the differential, which is to look at which types of white blood cells are they. The differential can be done in two different ways. They can either say the count, which is the actual, there are this many neutrophils, this many lymphocytes, this many monocytes, or they can do a percentage. So however many cells there were, we make it a percent, which means out of 100. So if there were 100, there would be 50 neutrophils, 17 lymphocytes, blah, blah, blah. So when it says a percentage, it has to add up to 100. So if one's low, another one's high, right? And then platelet count, we're counting those platelets. And if you remember, platelets are just a little piece. They actually could have been turned into white blood cell membrane. That's what they are, little pieces of basically the same thing as white blood cell membrane. And so we're looking at either the count of them or the volume, that if you separate them out, how much total quantity. And that tells us how big they are too. So are they large or small pieces? And so here's just our different cells, right? If you remember, our biconcave red blood cells, it allows them to hold more, kind of shrink and expand, those little pieces of platelets. And then our white blood cells are really big. And look at, that's a neutrophil. Look at that membrane, or that nucleus there. And there they are going through the vessel. So we use the CBC a lot when we're dealing with childhood cancers. So let's first talk what's different between adult and childhood cancers. Well, where they get it. Kids, it tends to be in the tissue instead of the organs. And where do they get it? Well, blood. That's our leukemias and lymphomas. At lymph, brain, bone, kidney, muscle. Where adults, it tends to be in a specific organ, like in the breast, in the lung, in the prostate, the bowel, or the bladder. As far as environmental factors that contribute to it, minimal for childhood cancers, where it's very much a contributing factor for adult cancers. On kids, usually it's just detected because they were looking for something else. On adults, we have detections, preventative screenings that we can do. I guess that's not really preventative, but early detection screenings that we do. And then the good thing is childhood cancers, we have much better rates of the cancer being responsive to treatment than we do with adult cancers. So common things that we do to treat childhood cancer: blood transfusions, supplemental oxygen, splenectomy. Often we have to take out the spleen. Either it becomes totally ineffective anyway. We call that they're functionally asplenic, so their spleen doesn't function, or it's damaging cells and we have to take it out. Hemopoietic stem cell transplant, IV hydration, lumbar puncture, and radiation treatment, and let's look at some of those. So when we do transfusion, we have different choices. We can give whole blood or we can give just a part of the blood. Whole blood usually is when we need that volume. We need everything in there and we need volume. So that's when somebody's lost a lot of blood, an acute hemorrhage or a trauma. Often we separate out the red blood cells. So if they're anemic, the definition of anemia is having a low red blood cell count. So all we do is give them the red blood cells. And some disorders that cause anemia are thalassemia and sickle cell disease. Platelets, right? This is clotting. So we can give those if their platelets are low, thrombocytopenia, or there's a risk of bleeding. Often we aren't going to give just platelets though. We'll give plasma, and we give it in the form of fresh frozen plasma, FFP. So plasma, right, that's the liquid portion of the blood. You just take out the red cells and the white cells. So we'll give that again when there's the risk of bleeding, because it's got all those platelets in it and it's got the clotting factors in it. So with hemophilia, they don't have a clotting factor. So if we don't know what kind of hemophilia, we could give plasma. Usually we're going to give just whatever clotting factor it is they don't have. And then DIC, disseminated intravascular coagulation. In DIC, you use up all of your clotting, your platelets and your clotting factors, because you make microclots in the vessels. So when we do a blood transfusion, right, this takes 2 licensed people to double check the blood type and the label and the patient. We're going to closely monitor vital signs and follow your policy, but I guarantee you're doing it beforehand and you're staying in there for the first few minutes, because the most common reaction or the most severe reactions usually happen quickly. So and then there'll be policy, and this can vary of when you take vitals again. If you increase the rate, usually we start slowly and then increase the rate. So if there is any concern that you suspect a transfusion reaction, you immediately stop the transfusion and disconnect it. Then flush that IV, because we want to keep that IV working, but we want to get that blood away from the patient. Don't throw it away though. We're going to reassess their vitals, notify the provider. They're going to want to know what those vitals are. So hopefully we have them on a monitor, and that only takes a second to do. And then everything is going to get sent back to the blood bank. So the tubing and the bag, everything. So when we give blood products or chemo, these kids who have cancer, they usually will have some sort of a central venous access, and these are some of the metaports that we use. The nice thing with metaports is they're under the skin, so when they're not in use, there's nothing hanging out. This one has been accessed. So the port is under the skin, and then we put a needle into the port. And now this is out where we can use it. But underneath the skin, you've got a port. This one actually has two ports here that you could put it two different needles in to give two different incompatible things. These are all just different types of ports. Broviac catheters we use a lot at Valley Children's. The difference with a broviac catheter is there's always something hanging out. So what you see on the baby's chest is always there. We're going to teach the parent how to change dressing, how to clean it, but it's always there. And I don't have a picture, but we use a lot of PICC lines, peripherally inserted central catheter, as well. The nice thing about a PICC is those are put in by a nurse. The others are put in by a physician, and broviacs and metaports are put in surgery by a surgeon. Hopefully you can see a huge cost difference there. So it makes PICCs very cost effective. So what is chemotherapy? Well, this is the drugs that we give to treat cancers. Usually we use a combination so that we're trying to kill those cancer cells from a couple of different actions. The cancer drugs, the chemotherapy, stops those cancer cells from reproducing. And if you remember, cancer reproduces rapidly. So chemotherapy kills all rapidly reproducing cells. So it kills the cancer cells, but it also kills the bone marrow, the lining of the GI system, especially the mouth, the hair, and the reproductive system. So side effects we get from treating cancer from chemotherapy, we destroy their immune system, so they're at risk for infection. They're at risk for hemorrhage because they may not have enough platelets. They're at risk for anemia because we've destroyed the bone marrow. It's not making enough, which is why we end up giving them lots of blood products. Nausea and vomiting, right? It does that GI damage. Anorexia and altered nutrition. They just feel crummy. Mucosal ulcerations, they get horrible sores in their mouth sometimes. You can get neurologic problems like that nerve pain, neuropathy, hemorrhagic cystitis, so blood in the bladder, alopecia, that's losing your hair. We put them on high doses of steroids, so you get the moon face, and mood changes can go along with those. So here's just some pictures of some of the side effects from chemo. Many kids will get radiation. So radiation is pinpointing X-ray to destroy the tumor, or sometimes to destroy the blood flow to the tumor. Many of the cancers, we can do a hematopoietic stem cell transplant. Now, when we talk about stem cell transplant, this is a cure or a kill. So we don't do this unless we really are out of other options. But we're going to try and find the best match we can. So somebody who has the same proteins on their blood, so they're histocompatible. And usually a sibling is the best choice, most likely to be a good match. Then we collect stem cells from the donor. Depending on who's needing to receive it, they can take it peripherally, so they'll put an IV here, take blood out, spin off stem cells, and return the blood. Or they will take it from the pelvis and actually draw actual marrow. The vast majority of donors give peripheral stem cells, not from the bone marrow, or not marrow from the pelvis. However, for children, when the child's the recipient, they're more likely to do that actual bone marrow as opposed to peripheral stem cells. Anyway, however they get that, they take those stem cells, which can become any kind of cell, and they give them to the recipient in an IV. But we need to make sure that it's a compatible donor, and before they get it, we totally wipe out their own marrow. So they're